morning, everyone. Welcome to this symposium on sexuality and COVID-19 as part of the COVID-19 in the Americas conference organized by the AHF Global Public Health Institute at the University of Miami, the Institute for Advanced Study of the Americas at the University of Miami, and the International Association of Providers of AIDS Care. I'm Antón Castellanos Usigli, a public health professional working as a consultant for the AHF Global Public Health Institute at the University of Miami. I'm also a Doctor of Public Health candidate at the Harvard THN School of Public Health and a member of the Global Advisory Board for Sexual Health and Well-Being. Today, I will be the moderator for this symposium. COVID-19 has touched all the aspects of our life, including sexuality. Due to the lockdowns, many people have abstained from having sexual relations, and some speculated that this would result in a significant drop of sexually transmitted infections worldwide. However, there are reports of STI transmission during the lockdowns. Few public health departments have addressed sexual health in the response to COVID-19, although the desire for sexual pleasure and intimacy is one of the reasons why people get in close contact with each other. During the pandemic, millions of people have turned to social media and dating apps to experience sexual pleasure and intimacy through online connections. COVID-19 has also brought upon times of financial hardship with direct consequences on sexual health and sexual rights. A survey conducted by the Guttmacher Institute in the US revealed that 1 in 3 women had to delay or cancel sexual and reproductive care, or had difficulties accessing birth control. Lower income women have been the most affected. According to the Human Rights Campaign, LGBTQ people in the US are more likely to live in poverty and to face barriers to access healthcare, which puts them at greater risk for COVID-19. Amnesty International has indicated that sex workers in Latin America face extremely difficult financial and social conditions during this pandemic, which puts them at higher risk of violence and health problems. Today, we will discuss these and other issues of sexual health, sexual rights, and sexual pleasure in the COVID-19 pandemic. I want to ask both the panelists and the audience to keep these 3 concepts in mind. What we call the triangle approach, a conceptual framework that we developed at the Global Advisory Board for Sexual Health and Well-Being to address sexuality. Sexual health, sexual rights, and sexual pleasure are deeply interrelated. They form a triangle that needs to be addressed in policies, programs, and services to support the health and well-being of everyone. I now want to introduce our stellar group of speakers. We have leaders from the private, the public sectors, the non-for-profit world, and academia. I will start with Ben Wilson. Ben is the Global Category Director for Sexual Well-Being at RB. Prior to this position, he was the Marketing Manager at RB China. In this role, he led the innovative marketing campaigns of Durex China, as well as Vit and Int'l. Ben is particularly focused on social media and digital outreach and leading the way in building brand advocacy. In the past, Ben was a marketing manager at RB in the UK. And prior to RB, he spent 10 years working in Johnson & Johnson in various marketing roles on skincare brands as well as healthcare. Dr. Demetre Daskalakis is the Deputy Commissioner for the Division of Disease Control at the New York City Department of Health and Mental Hygiene. He directs all infectious disease control programs for New York City, including HIV, tuberculosis, sexually transmitted infections, vaccine preventable diseases, the public health laboratory, and general communicable diseases. His division is one of the largest in the department, employing more than 1,100 staff, managing more than $350 million, and operating 14 clinical facilities. He received his medical degree from NYU, completed his residency at Beth Israel Deaconess Medical Center in Boston, and he completed his clinical infectious disease fellowship at the Brigham and Women's Mass General Hospital Combined Program. He also has an MPH from the Harvard THN School of Public Health. Giselle Carino is a change maker and a feminist activist. She is the CEO for the International Planned Parenthood Federation Western Hemisphere region, where she leads a network of 24 autonomous local partners that work to guarantee that sexual and reproductive health and rights are a human right for all. In 2019 alone, the IPPF Western Hemisphere Regions Network provided more than 24 million healthcare services in the Americas and the Caribbean, the great majority of them to women and girls. She is a native of Argentina, serves on the board of directors of Women's Link Worldwide, Catholics for the Right to Decide in Mexico, and the Center for Health and Gender Equity. Dr. Jhonny Lopez Gallardo is the executive director of CIES, Sexual and Reproductive Health in Bolivia. He is a medical doctor specialized in epidemiology with a master's of public health and a master's in business administration. Prior to CIES, he worked at the Minister of Health in Bolivia in a nationwide project funded by USAID. He was also a consultant for UNICEF's program for sexual and reproductive health, child survival, and nutrition in Bolivia. He has been the president of the PROCOSI Network for Comprehensive Health, which gathers different NGOs in Bolivia working for health, social development, and human rights. And finally, but not least, Terry McGovern is a professor and chair of the Heilbrunn Department of Population and Family Health at Columbia University's Mailman School of Public Health. Her research focuses on health and human rights, sexual and reproductive health and rights, gender justice, and environmental justice. Terry founded the HIV Law Project in 1989, where she was executive director until 1999. She successfully litigated numerous cases against the federal, state, and local governments, including SPV Sullivan, which forced the Social Security Administration to expand HIV-related disability criteria. She was also a senior program officer in the Gender Rights and Equality Unit at the Ford Foundation. So I will now begin with the first round of questions to all of the panelists. Each person will have 7 minutes for this first question. And to the audience, remember, you received a link to ask questions, which we will discuss at the end. So let's start with Ben Wilson. Ben, I know that since the beginning of the pandemic, Durex has collected a lot of data about the impact that COVID-19 is having on people's sexual lives around the world. What can you tell us about the impact that COVID is having on people's sexual lives? And what can you tell us about the situation in the Americas?
Thank you, Antón, and thank you for inviting me to be on the panel. It's a great privilege to be able to be here with you guys. As you say, yeah, well, I mean, from the start of the pandemic, one of the things we did was make sure we really stay connected with consumers. We do it, you know, every day, all day, and, you know, have been doing it for many years now. But since the pandemic, it was really important for us to connect. I think in terms of what we've seen, I think, you know, some very obvious things. So biggest drop in sexual occasions, those most impacted by lockdown situations. So if I take Italy as an example, one of the first countries to lock down, we saw a massive decrease in terms of sexual occasions in Italy very, very quickly, because the people who were, you know, the young people weren't able to connect, and therefore a massive drop. If I then flip that versus somewhere like China, where people tend to be in much more committed relationships and therefore actually living together, we observed a much smaller drop in terms of sexual occasions. So it's really been dependent on, you know, very localized what's happened from a lockdown point of view in terms of the overall impact that we're observing in terms of sexual occasions. I think, unsurprisingly, singles and couples have been the, you know, the most, you know, hardest hit during the COVID. And, you know, we really observe, you know, beyond physical separation, really the increase in anxiety that's caused. So even with couples then living together, the increase in anxiety, whether it be around COVID itself, whether it be around, you know, jobs, you know, looking after the family. You know, I certainly had to homeschool for 3 months, and homeschooling as well as managing a job was a pretty tough time. So what we're seeing is that anxiety is actually playing out, you know, heavily in terms of, you know, the frequency of sex occasions and really what's happening from, you know, from even couples who are together. And as, you know, as things have eased, we've seen that the anxiety has remained. So whilst some of the lockdowns have eased and then physically people are able to meet up more, we're still seeing that the anxiety is really enduring. Unsurprisingly, with anxiety, you know, we're seeing, you know, particularly, you know, sex drive decrease and overall dissatisfaction with one's sex life decreasing. So we're seeing a huge impact in terms of how people are and how satisfied they are. Unsurprisingly, we're observing things like increase in solo masturbation. So, people in solo masturbation occasions, and that very much links with, with being alone, but even in couples, not finding that time together. What we're seeing is that, proximity and a lack of distraction is driving some couples to have more sex. So some people are enjoying the lockdown and are having more sex. And it's really, they don't have distractions. They are physically together. And typically these are couples who've yet to have kids. So, tend to be, in the apartment, in the home together. We haven't seen major changes in, things like contraceptive choice. What we have observed is a massive drop-off in condom usage in places where lockdowns have impacted people meeting up and having sex. But overall, we haven't seen any real major changes in terms of contraceptive choices. And Antón, you referenced it earlier. I think under 24s and non-heterosexuals are really two groups that we've seen massively impacted during COVID. And those two areas are the ones that we're seeing the biggest impact overall from the COVID crisis. At the same time as sort of some of the negative things that are happening, we are seeing some some real positives changing out there. There's a real craving for intimacy now, and I think missing that connection is really what people are now craving. We've seen an increase in sexual hygiene, interestingly, and we've seen that across the board. It's not just in developed markets, it's in developing markets as well. It's all over the world, but seeing really people becoming more concerned about their sexual hygiene and the practices that they do around sexual hygiene. We see a feeling of loss of attraction, and more insecurities, self-care, self-love, mental well-being really becoming much more important for people now. And really interesting to see that alongside some of the hygiene habits and potentially how that can shape some of the sexual habits moving forward as people think much more about self-care and hygiene as a much more proactive approach to life in general. And it's going to be interesting to see what that means in terms of approaches to things like STIs moving forward. So I think overall we've seen some significant changes. I guess one of the big underlying changes as well is the move online and the move digitally, and whether it's consumption of porn going up, whether it's virtual dating, whether it's other activities, right through to how you buy your products, how you get access to contraception and to other sexual wellbeing products. We've seen that there's been a massive digital inflection. And actually we think this is really exciting because one of the barriers always within our category and within trying to get, for example, contraception in the right places, helping people prevent STIs, is typically a lack of education and a lack of access. And often that's also linked with things like embarrassment. People embarrassed to buy, people embarrassed to ask questions. So we're hoping that through the digital inflection, some of the trends that we're seeing in terms of more online activities, more searching online, more investigation online, and more purchasing online, that hopefully this can be an inflection and we can actually use this point in time to actually start driving the right content, to start driving some changes in behavior in terms of how people can access education and also access products. I think unsurprisingly, we're sort of waiting to understand in more detail the impact of the unavailability of services. Obviously in terms of people accessing services, again, that's dependent by country. It's also very much dependent within a country by different demographics. It can be simply where you live. It can be your certain demographic as well. And we're seeing a massive drop-off in terms of services. And to be honest, we're yet to really understand, what impact that's going to have. I think the other key challenge we have with this drop-off in services is when can we get the services restarted? When can we get that access going again? Because even some of the most basic, healthcare services are still limited in a lot of places. So the key challenge really is how can we potentially use an opportunity like the digital inflection along with the drop in access to services, and how can we try and bring these things together to try and hopefully make a positive change in terms of how we can move forward, particularly around things like STI control and things like that. So I think overall, Antón, it's been a tough time for people, particularly those younger single people, particularly non-heterosexuals, the people who haven't been able to connect. It's been physical and it's been emotional for them as well, sort of thing. So moving forward, I think, our drive is very much going to be focused on, the reconnection, but also importantly, the emotional side of it. I think often we lose some of that, particularly in the digital world, where everything becomes a little less intimate, but really focused on how we can try and create that intimacy and get that emotional connection going again.
Thank you so much, Ben, for this amazing picture of what's happening around the world with COVID and sexuality. I now want to give the floor to Dr. Daskalakis. So the New York City Department of Health has put forward sex-positive guidelines for sexual health during the COVID-19 pandemic. There was even a New York Times article written about these guidelines. Dr. Daskalakis, what has been the HIV/STI epidemiological picture during the pandemic in New York City? And what can you tell us about the importance of pleasure-based sexual health messaging during this pandemic?
Great, thank you so much for having me. And I will start by saying that that the New York City Department of Health, at least within the last 7 to 8 years, even before COVID, had really moved a lot of their messaging around sexual health, especially HIV and STI, to be very much focused on pleasure rather than on risk. And so I'll give really an example historically of that, and then we'll go into sort of what prompted our work in sort of a harm reduction strategy for safer sex during the age of COVID-19. About 6 years ago, when we were launching our HIV pre-exposure prophylaxis projects in New York City, we rebranded all of our HIV marketing to use a couple of very important strategies. The first we called a status neutral strategy, which was that we created marketing that was both for people living with HIV and for those who were at risk, really not creating a zero divide between folks who had a positive or negative test, since really the care and services are very similar. We launched a program that was called PlaySure. Our network is named after that, and our campaign was called PlaySure, our public messaging campaign, which was very much on a play on words to give people the idea that they are able to sort of use other options for safer sex beyond condoms. So that is both the notion that folks who are undetectable, who have HIV, do not transmit the virus, so the U equals U notion, as well as pre-exposure prophylaxis. And so we asked people to have pleasure and to play sure, and the double entendre was that it's supposed to sound like pleasure, which thankfully was not lost on many New Yorkers who saw that campaign and saw a very important shift in our messaging. So as COVID-19 emerged in February and March in New York City, we were very clear that it was important for us to have a very sex positive harm reduction strategy to address the surge in the pandemic, realizing that, again, though there was a lot of messaging around social distancing and isolation, that many New Yorkers may not choose to do that with their sexuality. And so in March, we released a version of this document that was very much focused during really what was the beginning of the peak of our pandemic, at least wave one, to really give people options of how they're able to navigate sexuality and some strategies to prevent COVID transmission. And I feel like we initially leaned very heavily on digital media. And so we encourage people to use dating apps and hookup apps, and we encourage people to use video conferencing, and actually also for our sex workers, encourage them to use subscription services, subscription fan services, to make their living, as opposed opposed to in-person encounters. So it became pretty clear that as our pandemic started, the first peak started to wane, that we were seeing that New Yorkers were no longer interested in isolation, and I think that that's probably a pretty consistent finding throughout the world. And so our guidance shifted even more drastically to give more harm reduction strategies in terms of how to meet safely and to potentially have safer sex encounters. And so one of the sort of most notable sort of things that made the media was that we even encouraged things like glory holes, saying that something that created a physical barrier between you from the upper body perspective, but allowed intimate contact is something that is a strategy to reduce harm. We also were able to release guidance that said that people should sort of explore kink, since masking was something that we recommended in the setting of having sex with COVID in the era of COVID-19. We encourage people to be creative and to think about different positions and use of masks and other things in consensual sex to allow them to have pleasure in person. We also did sort of talk about the issue of serologic testing and the fact that it wasn't 100% in terms of giving you a license to feel that you are no longer susceptible to COVID-19, and also added a testing dynamic to strategies very similar to the sero sorting ideas of HIV. And in fact, I want to go back and say that our March release of this guidance was actually based very deeply in the HIV epidemic. And so in the 80s, a document was released primarily motivated by community in New York City that was a guide to having sex during an epidemic. And so we took that document, which is really now a historical document, and used it to model our guidance for harm reduction during the COVID-19 pandemic. And rather than waiting for many, many months, or potentially, I think it was at that point, even a year or so since the dawn of the HIV epidemic, we wanted to be really putting it front and center of our guidance. Along with that, we also provided a lot of other guidance around sexual health, specifically around sort of crisis standards of sexual health. So since we realized that in-person visits at many of our sexual health venues were not possible, we released guidance around syndromic therapy of sexually transmitted infections. So rather than waiting to see someone with a drip or an ulcer, really giving strategies of how you can treat that both in person, if possible, as well as remotely in a scenario where testing and in-person encounters may not be possible. And so I think that really sort of capitalizing on the trajectory of our HIV and STI work, we were able to release this guidance and others to really maintain sexual health services and sexual health strategies. I mean, we're really proud of the fact that many jurisdictions have adapted it in some scenarios, cutting and pasting the entire guidance and branding it themselves, which I think is a pretty great compliment. But I think there's always sort of more to come. And I think we plan on revisiting that guidance as the pandemic continues to evolve. So I think that as we have a vaccine dynamic enter the picture, we're going to have to sort of be more clear from the harm reduction perspective about that. So I will leave the conversation about our harm reduction strategies. And since I know time is getting short, I want to just give you a quick view of what we saw in terms of our epidemiology of sexually transmitted infections in New York City during the pandemic. And I will share my screen, which I think I can do, and just really briefly go through a few slides. So what I'm showing you is going to be using our surveillance data, so our lab reporting. So in New York City, we actually get lab reports of all HIV testing, as well as lab reports of all sexually transmitted infection testing. So I'm able to give you a little bit of a story of what service interruption means. So what you can see is this is HIV-related laboratory reports by month. This is specifically CD4 cell counts as an example of what we've seen. So you can see pretty clearly that we had a significant hit to our care-seeking behavior for HIV, with, in fact, in April at our height, a decrease of 76% of people who are getting this like standard monitoring test. What you see is that as the pandemic first wave has regressed, we are starting to see an increase and a return to care. So that is similar. Similar data exists for viral loads, another piece of HIV care and monitoring. So you'll see again that we had a pretty significant dip in folks seeking care and getting this very important testing, and then subsequently a recovery, but still not quite to the levels that we had in our prior year. We also look to see what the impact was on HIV diagnostic testing. Now, I'll say we only get reports of positive tests, not positive and negative tests. But you can see again that there's a significant dip that occurred during the peak of the pandemic. And again, we have not recovered, as one would expect, our number of new positives in New York City. So I don't think that that is reflective of decreased transmission. I think it is more ongoing sort of fear of pursuing care, and then also potentially the dynamic of individuals using home testing as opposed to in-person testing. So we will continue to track this data to see if sort of what the trends are. I will also say that we saw an interesting trend in gonorrhea, chlamydia, and syphilis, and I think that there is a apocryphal observation that you can see in these data. So I will highlight what I think is happening and show my theory. So this is the number of chlamydia cases by month and year by report in New York City. The light blue is 2019 counts. The sort of green is 2020 counts. That is per month. The dotted lines represent cumulative diagnoses. And again, it's sorted by year. So you'll see that same U-shaped curve that we talked about before. You'll see also, however, that our cumulative counts of chlamydia have decreased in 2020. I don't think that's because of less risk, and I don't think that's because of less chlamydia. I think that people are hesitating to come to care. They're not getting asymptomatic screening, and also if they are symptomatic, they may be getting treated without tests. I will show you the gonorrhea curve, which looks identical, very similar. Now I'm going to say here's where I have my apocryphal theory: syphilis, primary and secondary, which is symptomatic. Please note that the two lines are identical in 2019 and 2020. So this to me means that people who had symptomatic STIs were likely still pursuing care, but that in fact, we may have been missing a significant number of asymptomatic individuals or individuals who may not have been tested and just treated. So I think that the syphilis line, given that folks tend to be very symptomatic by definition, but with primary and secondary syphilis, means that we likely will have an impact on what we've diagnosed. And I would be less than optimistic that this would result in decreased STI transmission over time, but in fact may represent some unseen transmission that we may or may not learn about until later. And with that, I will stop sharing my screen. Thank you very much.
Thank you, Dr. Daskalakis. And definitely the New York City Department of Health is an example, I think, nationwide in terms of incorporating pleasure-based messaging for the promotion of sexual health. So thank you so much. Now, if we think back on this idea of the triangle, I'd like to move the conversation a little bit more towards the sexual rights aspect. And so, Terry, I'm curious if you can tell us about the most important sexual rights challenges that have emerged during the COVID-19 pandemic in the Americas.
Thank you so much, Antón, and it's really a pleasure to be on this esteemed panel. So, of course, the pandemic has exacerbated social and economic vulnerabilities, disrupted sexual and reproductive health care and well-being, changed fertility preferences, services have been reduced, in part because resources are diverted, but often because lawmakers are using the crisis as a pretext to restrict rights. So, in countries prone to authoritarianism and regressive gender ideologies, all repression, exclusion, and criminalization have been heightened during the pandemic, and that puts marginalized populations at great risk. Just in the Americas, laws around LGBTQI people really vary, same-sex marriage being legal in 26 out of 35 states and all 21 territories of the Americas. 22 states and 14 territories have some discrimination protections for LGBT people. However, 9 nations still have criminal punishment for buggery, criminalizing same-sex activity, and even more countries lack protection against discrimination on the basis of sexual orientation. This threatens the ability of LGBT people to access necessary services. A rapid assessment by Outright International found that even in countries where progress has been made around LGBTQI rights, there's a higher level of vulnerability to accessing healthcare during COVID, unrelated to COVID. And we have research in 8 different countries, and this picture of LGBT people being extremely vulnerable and in fact, often experiencing police brutality is emerging very clearly. Let's turn to sex work. Sex work is widely criminalized across the Americas, including in the US. Some countries, Chile, Peru, Colombia, have legalized and regulated sex work. There are some governments trying to provide assistance to sex work during the pandemic. Mexico City, for example, providing temporary shelters and emergency funds, but this is pretty rare. A survey by the Global Network of Sex Work Projects found that the closure of bars, parlors, brothels left sex workers in Latin America extremely vulnerable, nowhere safe to work, earn money, and reside. They did not have access to the same emergency funds available for the rest of the population, reduced access to condoms, STI treatment, testing. So of course, as always, sex workers have organized and set up emergency funds for life-saving assistance on their own. But really, the criminalization and stigmatization of LGBTQI people and sex workers is a huge issue. I want to talk a little bit about the US and family planning. As you referred to earlier, a Guttmacher report found that 1 in 3 women want to get pregnant later. 1 in 3 women reported having to cancel or delay visiting a provider for sexual and reproductive health or birth control. Biggest barriers among women, Latinx women, queer women, lower income women. The online birth control market has kind of swelled to fill this gap, but it is not accessible for everyone, particularly people in rural communities, people on tribal lands. And of course, in the middle of the pandemic, the Supreme Court ruled in favor of the administration's bid to allow schools and employers to deny birth control coverage because of religious or moral objections. Abortion access has been used in various states. Lawmakers have used justifications like a need to conserve PPE or other things to restrict abortion access. Consider the risk in states that have in-person counseling requirements. There are so many restrictions at this point, and in the pandemic, it makes it virtually impossible in many states. There's been lots and lots of litigation around this. Of course, medicated abortion is safe, and providers are reporting an increase of women seeking medication abortion. But in 18 states, abortion pills cannot be prescribed remotely. Of course, on birthing people, a study found in New York City, COVID transmission among birthing people is associated with household crowding and lower socioeconomic status. Obviously, we know COVID is exacerbating all kinds of discrimination. And we see that a lot in the birthing data. Coronavirus hospital protocols are shortened for postpartum hospital stays. This increases risks. And of course, as has been referred to repeatedly, STI screening and treatment. Although some services are available online, the cost is a significant barrier in many states because online providers don't take insurance, public insurance. The long-term impacts of all of this we will see over the years. I think Demetre talked about most of this, but The outreach, education, and prevention efforts around STIs is really a problem in many states all over the country. I think the decrease in preventative care will have long-lasting impacts, particularly on low-income people and people of color. Let's just talk about detention centers for a minute. So detention centers lack basic health and hygiene services along the US-Mexico border. In Texas, community health workers are no longer able to go door to door for essential sexual and reproductive health services. And as you all know, public health has been invoked by this administration as a pretext for denying asylum to people in need, even pregnant women. And they are being held often in Mexico, awaiting some word in terrible conditions. The many media outlets have highlighted the increase in gender-based violence all over the place, obviously without access to schools or other public centers. There are all kinds of issues there. Just quickly back to the Americas. In Argentina, the pandemic was invoked to stall a law that would legalize abortions in the first 14 weeks. I'm sure Giselle will talk about this survey in Colombia. Women suffering disproportionately, sharp increases in calls to hotlines. I am struck so much by how often I'm using what I learned in HIV. Specifically, even the stuff around who's going to get the vaccine, who's going to pay for the vaccine. I find myself back in the land of TRIPS flexibilities and invoking the right to health to overcome long-term patents. I predict that these same issues that we continue to grapple with in HIV, that we're seeing in COVID, are going to, completely be front and center around vaccine rollout. Who gets it, who pays for it, what is a human rights-based approach. So much more to say, but I'll stop there.
Thank you so much, Terry, for this fantastic journey on the impact that COVID-19 is having on sexual rights in the US and Latin America, and definitely affecting the most vulnerable populations. Giselle, IPPF Western Hemisphere region is the main provider of sexual and reproductive health services in Latin America. How has COVID impacted your network and the populations in Latin America that are the most disenfranchised?
Thank you so much. Thank you so much for the invitation to be here, Antón. Thank you to all of you. It's been great to listen to all of you. I just wanted to begin, because it's rather a bleak question, the one that I have to answer, with some good news coming from Chile. Last weekend, Chile voted to have a new constitution drafted, one that is not in the context of the dictatorship like the last one, and with gender parity. So that was conquered by women and girls, but people on the streets, not because of COVID, but in spite of COVID. And we are very proud of what could happen there and what we have to learn. So the impact for COVID on the Latin America and the Caribbean, I think it's important for you to know that we, for those of you who are not familiar with IPPF WHR, we are a network of 24 local partners in 18 countries that are united by a common mission to ensure universal access to SRHR services, to eliminate violence against women and girls, provide sex ed, and fight for sexual and reproductive rights. We have partners all across the Americas, Canada, the English-speaking, French-speaking, and Spanish-speaking Caribbean as well. And I'm very happy that Jhonny from CIES Bolivia, one of our partners, is here as well. So the impact of the pandemic, by March, when New York City went on the lockdown, we had 32 countries on lockdown. All our services closed down, all the clinics closed down, all the community programs closed down. Very strict lockdown measures in some countries, dividing folks who could circulate in specific hours by gender. So there were days in which women can go out for an hour, days in which men can go out. You can see how the gender ideology is playing out in some of the lockdown measures already. We know, and I think Terry talked about this, and this is also what we have experienced. Women, particularly undocumented migrants, Black, Latino women, Indigenous women, are the main caregivers at home and paid work. And during the pandemic, they have also been the frontline healthcare workers in Latin America and the Caribbean, and the domestic workers. So we have a lot of clarity that in the 5 years, when we look at the COVID-19, we look at also in the 5 years since we had the Zika epidemic, although these are different pandemics, different health emergencies, difference in magnitude and the impact, we understand that there are important lessons we fail to learn in trying to protect women and girls and more vulnerable populations. At the beginning, we would hear in the news things saying, the pandemic is very democratic, the virus is democratic. Well, we know now it's not. It actually not affects those with less privilege the most, and the data is pretty clear. In terms of SRHR, we have a situation which is, I think, an emergency situation. We have data here that I'm showing from the latest report from the UN Population Fund in August, showing different scenarios of unmet need of contraception in the context of COVID. They're showing here the most pessimistic scenarios, which can actually double the number of women who experience an unmet need for contraception in Latin America and the Caribbean. If one thing we have learned over the past few months is all of our pessimistic, less likely scenarios became a reality very quickly. Here, as you know, the role of access to contraception in reducing maternal death, infant death, I think we face a situation in which we could come back 40 years, about my age, in access to contraception. Gains we fought very hard to deliver for women and girls in the region are at risk by the pandemic. Also, we are looking at some data that is concerning us on maternal mortality. We have a hard time trusting some of the official surveillance data, but some of our colleagues are doing very important work to dig on this. And we are looking at data from Brazil and Mexico. In the case of Brazil, more than 200 women have died since the onset of the pandemic. 3 in 4 of the total maternal mortality in the world of COVID. 3 in 4, twice the number of all the rest of the world. And I think, we have to ask the question, why are these women dying? Are they not accessing prenatal care? It's just that. Are they dying because they're poor? Who are these women? The data we have, it's very clear that the number of Black women dying, it's about double. So we have to look at that, I think, and call attention to this, because it's a very important marker. We also have some data from Mexico that we are following very closely here. Abortion access, we live and are part of one of the regions with most abortion restrictions in the world. And access to the legal abortion, it's very much restricted. In the context of the pandemic, there is a burden on high cost. Income has gone down. People are out of work. We have seen the data for Latin America and the Caribbean on rising unemployment levels. And we also know that in some of the public hospitals, we develop an observatory and are following very closely 10 countries. And we know that providers, just much like in the US, are being asked to shift to tend to COVID patients. And we have a shortage of abortion providers. So we have also have had a shortage in the context of the pandemics of commodities, very important life-saving commodities for abortion care. Gender-based violence, I think Terry talked about, the numbers are peaking. The reports, though, the police reports are not moving up as they should. And so we did some analysis and understood through our observatory that police stations operate in shifts. Women cannot get there. There are not safe channels of communication with women. Homes are not safe spaces for women. and poor monitoring from some governments. The case of Ecuador, I was shocked to learn, it's part of our observatory as well. You know, when women go to a shelter for violence, mostly with their children, they are in a life-threatening situation. In the case of Ecuador, the government was requiring women who suffer violence, who were in this situation, to get a COVID test. And that might make sense from a public health stance, but fails to look at the consequence, which is that it takes weeks to get a COVID test done, the result back, and that means you're simply not there to tell the story, right? So I just want to mention that, Fiona, you know, for us, it's very clear through the data, through the experience our partners are having on the ground that, you know, putting women's sexual and reproductive health at the center of the response, including access to reproductive health care, should be central. I can remember every single emergency. I'm thinking of the Hurricane Maria in Puerto Rico. We always work to make sure that women's rights issues, reproductive care is central to the response, to consider these services essential services. And every time we have an emergency, whatever emergency is, we have to go back because they are dropped in the list. And finally, looking at really intersectional gender lens to social protection policies and health policies combined to support care, right? Women are caretakers, and they need to be taken care by these two working in tandem. So I'll end here. Thank you very much.
Thank you so much, Giselle. As you said, COVID has deeply affected women of color and women living in situations of poverty. And you raised a very important question. Why have SRHR services, they haven't been considered essential in the COVID-19 response? And why is that, and the implications that this has for the health and well-being of all? So now we will go with Jhonny Lopez, with Dr. Jhonny Lopez. I will be translating from Spanish to English, what Jhonny will share with us today. And so, Jhonny, what can you tell us about the impact that COVID-19 has had in the access to sexual and reproductive health services among indigenous communities in Bolivia? Dr. Jhonny, ¿nos podría comentar sobre el impacto que ha tenido el COVID-19 en el acceso a servicios de salud sexual y reproductiva en comunidades indígenas en Bolivia?
Muchísimas gracias por la invitación a Antón y a todos los participantes. Pues claro que sí, pero antes quiero referirme a CIES. CIES es una ONG boliviana que trabaja en los derechos sexuales y derechos reproductivos, y para ello cuenta con 16 clínicas y 3 unidades móviles de salud que prestan servicios gratuitos a comunidades rurales e indígenas.
Thank you so much for the invitation. I want to start by talking about CIES. CIES works in sexual and reproductive health and rights in Bolivia. They have 16 clinics in the country and 3 mobile units. They provide free services for rural and indigenous communities.
Al año prestamos más de 500,000 consultas externas. También prestamos servicios educativos en educación sexual integral a más o menos 5,000 adolescentes y jóvenes en 250 escuelas públicas.
Every year, CIES provides more than 500,000 SRH outpatient consultations in their clinics. They also provide comprehensive sex education to 5,000 adolescents and young people across 250 public schools.
A la vez impulsamos procesos de abogacía e investigación y somos considerados una organización nacional líder en la defensa de los derechos de las mujeres y de las jóvenes. Una acción clave de nuestro trabajo es llegar a áreas periurbanas y poblaciones rurales geográficamente aisladas.
CIES also promotes processes of advocacy and research. They are a leading nationwide organization in Bolivia advocating for the rights of women and youth, and they especially focus on trying to reach peri-urban populations and rural populations.
Durante la pandemia, las restricciones de movilidad y aislamiento redujeron el transporte público e impidieron que las mujeres dejen sus hogares para acceder a servicios de salud sexual y salud reproductiva.
During the pandemic, there were several restrictions for public transportation, limiting women's access to sexual and reproductive health, particularly women in rural and indigenous communities.
Impidieron que las mujeres del área rural viajen desde sus municipios donde viven a los centros para recibir servicios de salud.
So these prevented women living in rural areas for them to reach out to clinics where they could receive SRH services.
Asimismo, el gobierno estuvo enfocado en responder a la pandemia del COVID-19 y no incluyó los servicios de salud sexual reproductiva en la agenda. Esta situación es alarmante porque los servicios de salud sexual y reproductiva no han sido considerados como servicios esenciales, sobre todo aquellos dirigidos a poblaciones como mujeres, niñas, adolescentes, poblaciones indígenas.
The government didn't include sexual and reproductive health in their agenda to respond to the COVID-19 pandemic. This is an alarming situation, as sexual and reproductive health was not considered essential, leading to further exclusion, marginalization of women and girls, particularly living in rural and indigenous communities.
Por ejemplo, durante la pandemia, el sistema de salud pública no ha brindado servicios de planificación familiar ni atención a jóvenes y mujeres.
During the pandemic, the public health system has not offered family planning services and sexual and reproductive health to women and youth.
Frente a esta situación, CIES ha presentado propuestas ante la fragilidad del sistema público en infraestructura sanitaria, falta de personal capacitado e insumos, afectando esta situación a las poblaciones más vulnerables.
In light of this response, CIES has provided strategies to face the lack of infrastructure, staffing, and commodities at the public health system, particularly thinking of the most vulnerable communities.
En esta crisis sanitaria, la telemedicina ha sido un canal poderoso para la atención a las mujeres y poblaciones en mayor situación de fragilidad.
Telemedicine has been a powerful channel to provide services to women and populations who face situations of vulnerability and exclusion during the pandemic.
Hemos ampliado especialidades médicas por esta vía y ahora ya estamos ofreciendo servicios, por ejemplo, de ginecología, orientación en anticoncepción, psiquiatría, una serie de especialidades que los médicos están dispuestos a brindar a través del uso de la tecnología.
CIES is now offering OBGYN, contraceptive counseling, and psychiatric services through telemedicine.
Es importante resaltar que en Bolivia hay pocos datos accesibles y desagregados, por ejemplo, en temas de violencia de género. No tenemos datos de edad, raza, tipo de violencia, relación de la víctima con el agresor.
Another challenge is that in Bolivia, there is not enough data about situations related to sexual and reproductive health that have been happening during the pandemic. For instance, gender-based violence. They don't have data on the type of violence that is happening, the age of the victims, the type of the relationship of the victim and the perpetrator. There is not enough data.
La pandemia nos dejó muy claro lo importante que es tener datos epidemiológicos desagregados, que son fundamentales para el desarrollo de políticas públicas en salud sexual y salud reproductiva.
The pandemic has shown us the importance of having transparent epidemiological data to develop policies, including policies on sexual and reproductive health.
El gran impacto de la pandemia, particularmente en un contexto de desinformación, de crisis social, financiera y crisis política, fue la falta de información integral y oportuna.
A key aspect in the negative impact that the pandemic has generated among the population in Bolivia within a context of financial and political hardships has been misinformation. There's been a lack of comprehensive information on what's happening.
Con un gobierno en transición, en un contexto de campaña política, falta de recursos humanos, médicos capacitados, el impacto fue devastador para la población.
With an interim government during electoral times, lack of staffing, human resources, and commodities, the impact has been devastating for the population in Bolivia.
Hoy tenemos más de 140,000 casos positivos de COVID y más de 8,600 muertes. La población más afectada, la población vulnerable, mujeres e indígenas de zonas periurbanas y de comunidades rurales.
Today, there are more than 140,000 positive COVID-19 cases in Bolivia and more than 8,600 deaths. One of the most affected populations have been indigenous women living in peri-urban and rural communities.
No puedo dejar de mencionar el contexto también de la población boliviana machista y conservadora, que ha tenido también un efecto. Sin duda, el incremento de embarazos no deseados en población adolescente y joven, el incremento de la mortalidad materna.
Finally, I have to mention the context of machismo and conservatism that has resulted in increased rates of unwanted pregnancies, maternal mortality, and increased rates of gender-based violence.
La violencia basada en género de alta frecuencia e intensidad, 96 feminicidios que se han reportado y el 60% durante la pandemia. El incremento de casos de infecciones de transmisión sexual, pero también el acceso de servicios a tratamiento de VIH.
Gender-based violence has increased substantially in Bolivia. They've had 96 femicides, 60% of them happened during the COVID-19 pandemic. There's been an increase of STIs and lack of access to HIV medical care during the pandemic.
Gracias.
Thank you so much, Dr. Jhonny. So I remind everyone who is listening to us that you received a link to put questions. So we will have some time to discuss those questions at the end. And so yesterday, Julio Frank, the president of the University of Miami, talked about the importance of building a better normal post-COVID-19. So I will ask the same question to all the panelists, and each person will have up to 4 minutes to respond. So what are some of the new opportunities that exist to promote the triangle of sexual health, sexual rights, and sexual pleasure post-COVID-19? Let's start with you, Ben.
Thank you, Antón. I think for me, the big opportunity is really the digital inflection, which I mentioned earlier. I think, we've heard it come through a couple of people here in terms of, things like telehealth and, some of the inflections that are happening. So for me, I'm really excited with the potential opportunity we now have to really connect with people through digital and use that really as a very sticky way of being able to bring them through the services that we need. Whether that be more educational, whether it be access to products, or whether it be access to treatments. So I think that's the area that is really interesting. I think the second area then for me is then linking, public and private up more. We've seen a lot of public and private coming together through the crisis to really fight against things together. And I think, that's going to be really interesting in terms of, does that create new opportunities? I hate to say the new world, but in the new world, is there, opportunities for public and private to become closer within that. And then finally, the third area for me is as we develop a lot of these capabilities with COVID, test and trace and things like that, how is that going to help us in terms of some of the areas where we are? Will it help us advance some of the services we're able to offer as well? So I think it's really interesting for me. So those are the three major areas, but really the big one for me is this digital inflection, which is happening.
Thank you so much, Ben, and definitely technology and creative partnerships between the public and the private sector are appearing as an opportunity. Dr. Jhonny Lopez, si nos pudiera comentar qué piensa sobre estas oportunidades. Creo que estás en mute, Jhonny.
Lo siento, I'm sorry. Creo que, como Ben indicaba, la tecnología es una oportunidad que irrumpe con mucha fuerza a través de la implementación de servicios de telemedicina. La pandemia ha puesto en evidencia que la telesalud es una inversión a largo plazo y un modelo de negocio innovador que tendrá un gran impacto en la cultura de las organizaciones que brindan servicios de salud sexual reproductiva y especialmente en organizaciones como la nuestra.
Technology and specifically telemedicine are fantastic opportunities. Telemedicine has disrupted healthcare. The pandemic has shown us that telemedicine is a great innovative business with promising impact for organizations that work on providing sexual and reproductive health, just as CIES.
En CIES estamos desarrollando algunos ejes de trabajo para fortalecer la información y el acceso a servicios por medio de la salud digital. Uno es en violencia basada en género, otro tiene que ver con el objetivo de mejorar el acceso a anticonceptivos, a consulta médica, reconsulta y finalmente la gestión digital del usuario.
At CIES, they are strengthening their programs, incorporating technology to tackle gender-based violence, access to contraceptive consultations, access to health services, and commodities for patients.
Hemos habilitado inicialmente líneas de WhatsApp y teléfonos para brindar consejería y orientación en salud sexual y reproductiva, así como atención psicológica, no solamente a las personas, sino a las familias. También enviamos recetas para acceso a medicamentos y en algunas ciudades hemos ofrecido entrega a domicilios, no solo de medicamentos, sino también de anticonceptivos. También hemos realizado el traslado de mujeres desde sus domicilios hacia nuestras clínicas por medio de nuestras ambulancias.
CIES has enabled WhatsApp lines, phone lines to provide sexual and reproductive health and psychological counseling to people, to individuals and families. They have facilitated sending prescriptions through digital channels, the delivery of medicine and contraceptives as well in certain cities, and they have worked to provide transportation to women from their homes to their clinics.
La pandemia nos hizo comprender en un contexto como Bolivia que es necesario fortalecer el acceso a servicios, a información e insumos de anticoncepción, a servicios de aborto. Sin embargo, aún existen barreras como la incapacidad de los proveedores de salud para enviar recetas a través de plataformas digitales, requisito de exámenes previos presenciales como ecografía. Esto obstaculiza enormemente la implementación plena de la telemedicina.
The pandemic has also shown us the importance of strengthening access to sexual and reproductive health services, commodities, and abortion. However, there are still obstacles such as providers not being able to send prescriptions through digital platforms and the requirement of having ultrasounds previous to an abortion. Thank you so much, Dr. Jhonny Lopez. So, Dr. Daskalakis, now let's go with you. What do you think in terms of the new opportunities to build a better normal post-COVID-19 when it comes to sexual rights, sexual health, and sexual pleasure?
So I'll start by echoing the critical importance that we've learned about telemedicine. The way that I like to think about it is that we have been working for decades to sort of get or at least a decade, to get telemedicine and other sort of remote methods for healthcare front and center. And I think that that COVID-19 accelerated that. I guess hindsight is 2020, but one always can imagine what it would have been like had we actually been able to develop telemedicine very well prior to the pandemic, but never miss out on capitalizing off of a crisis. This is something that we need to continue and persist. I think the telemedicine provides some really important strategies for mitigating stigma, which again is critical in receiving services. I think that the ability to call in or to Skype or whatever platform is used in allows individuals to interact in these very important areas without necessarily walking into a facility with a giant rainbow flag or a giant sign saying sexual health reproductive services. So I think that it's really an opportunity for us to see how we can better use technology to not only deliver service, but to mitigate some of the stigma that has been a barrier to those services. I'm going to say something that I think is a little controversial, but I guess that's sort of the fun of being on a panel. I think that what this pandemic has also taught us is that we need to stop over-medicalizing HIV prevention and sexual health. I think that one of the important lessons is that people can go on PrEP and stay on PrEP and don't necessarily need to be seen by a clinician every 10 minutes. Additionally, post-exposure prophylaxis, as an example, in New York City, when we were in the crisis of a surge and nowhere to go, we have a 24-hour hotline that used to provide 2 days of post-exposure prophylaxis as a starter pack before being able to sort of provide the full 28-day course to prevent HIV. We blew that out of the water and said, we don't care about your labs. We're not going to check. We're going to give you a home testing kit. Let's prevent HIV by providing this strategy without over medicalizing it with so many labs and so many visits. So I think that a very important lesson, at least looking at sexual health, and I think that can be taken sort of more broadly looking at reproductive health and other areas of sexual health, is that we've learned that we can do this in a high-tech way that is lo-fi from the perspective of medical intervention. And I think that that is a very important strategy to enhancing the services. And access to the services while mitigating, again, stigma and some of the perceived barriers. I think another important thing that we've learned is that we can use technology to figure out ways to allow for home testing. So I think there is a huge amount of interest. And I think many pilot programs, including one that we have in New York City, to do home testing giveaways, and they're wildly successful. And so I think we have to sort of listen to what the pandemic taught us, enhance those, and try to figure out a way to not only provide testing, but demedicalize HIV and STI prevention services, as well as other reproductive health services using similar platforms. So just like in so many other sort of venues with HIV and STI and reproductive health, testing tends to be sort of the central mission. And I think that we can then figure out ways to evolve the central mission to include elements of care beyond testing. And then finally, I'll give an example of like opportunity knocks sometimes with a crisis. And I'll give an example of what we've done in New York. And it's more of an example. We launched about a year and a half ago in one of our clinics, a rapid STI testing program, very similar to the Dean Street Express in London, which is a wonderful model. And so we launched that. It took us 2 years to get the funding, a year to sort of motivate construction. It was a lot of work. And so we got that done. In the age of COVID, we were able to enhance all of our sexual health clinics to include a laboratory space that allows for rapid diagnostics of gonorrhea and chlamydia. Right now, those venues are doing COVID testing. But when COVID testing becomes less critical, we will flip them over and use them for sexual health to mean that not only do I have one Dean Street Express in New York City, but I'll have 8. And that will deal with some of the very significant equity issues by allowing us to spread that service throughout the city rather than focused in only one part. So I think there are opportunities that knock, and you just need to be creative from the public health perspective to see how you can really improve COVID outcomes while simultaneously looking toward the future of how you can improve sexual health outcomes.
Thank you so much, Dr. Daskalakis. You raised very important points. I think when you refer to employing technology, not only to facilitate greater access, but also to reduce the stigma around sexual and reproductive health services, to demedicalize them. And so I think these are some of the opportunities that we can begin to think about as the pandemic progresses. So Terry, what is your take on this question? I think you're on mute.
Sorry about that. I agree about telemedicine. After Ebola, we knew if you were going to make people stay at home, you needed to address gender-based violence. And there are 1 million UN documents that say things that could be done, public service announcements, targeting folks, targeting men and boys. None of them were followed. I think we have to, as advocates, as public health people, really learn from this, that we have to, that these epidemics, this pandemic is incredibly politicized, and therefore basic things like the declaring GBV services or SRHR services were being done, again, totally politicized. We have known for years and years from HIV that criminalizing people, criminalizing sex work only hurts public health. And now we're going to have a whole new set of data that shows that, that certain populations are more affected. We know rural people in rural communities, indigenous people, like when are we actually going to make plans that address what we know? So I see that as an opportunity. Lastly, where I work, data is talked about as though it were, this, completely infallible thing. And we have lousy data on adolescents, on LGBT populations, on sex workers. So we need to demand better governance around what data is collected, et cetera. And I think sadly, this pandemic will give us an opportunity to really highlight all of these failings and get them right the next time.
Thank you so much, Terry. And I think the point about data goes back to the story of Jhonny and CIES in Bolivia and how he has noted a tremendous lack of data about sexual and reproductive health issues during the pandemic and not really knowing, for instance, what's really happening with gender-based violence. And also what you mentioned about the criminalization laws affecting LGBTQ community, sex workers, and how this continues to be an obstacle for people to achieve health and well-being, for people to live a life with dignity. So now I'm curious to hear what Giselle has to say, and just a quick reminder to everyone, again, we'll have about 15 minutes in a moment to discuss your questions. So please don't feel shy, type them in, and we want to hear from you. So Giselle, what do you think are the new opportunities to build a better normal post-COVID-19 in sexual and reproductive health?
Well, one of the problems of coming one of the last is that most of the things have been already said, and I fully agree, right? I also want to take a moment to say that this is one of the few times, and probably one of the good things about this moment in which we find where we can dispute the future. We can reimagine what the future. I mean, this question to me is very revealing in that we have, or gives me the sense that we can define the future we need and want. And in that sense, I of course agree with telemedicine. I think we in Latin America and the Caribbean is one of the region most better connected in the world. It is frankly amazing. Yet, I think the challenge for us is to take those programs to scale, to really have an impact, right? And we have not seen that yet happening. And I think that's a real frontier in front of us. Some of Demetre's comment made me think about when many of our organizations were built, they were not built with clinics. They were built with community programs and women-to-women care. Maybe this is the time to revisit that. Maybe this is the time to make investments in making sure that we can support some of those interventions. And finally, I would say putting a focus on the care economy. How we care for those who care is critical to overcoming any humanitarian situation, and in this particular one, the care question for those of us who have kids in school, when school starts and stops, for those frontline workers, from those women are central to the care economy. How do we put them at the center of the policies, the health and the social policies? I think is critical to create a new, better, hopefully normal. Thank you.
Thank you. And before we proceed to some of the questions that we've been getting from the audience, I'm just curious if anyone has a reaction from what was said from any of you, if someone wants to add an additional thought or comment before we proceed with the questions from the audience. So I have a couple of questions here. And so maybe Dr. Daskalakis, maybe you can respond to this one. So someone is asking if COVID can be transmitted through bodily fluids, sexual fluids. Yeah, specifically about sexual fluids and COVID-19 transmission.
Great question. So a couple of things. There have been some limited studies of seminal fluid that show that there is there is SARS-CoV-2 in seminal fluid. Studies, though, again, very small, studies of female genital secretions to date have not demonstrated the presence of COVID-19. There is also pretty good evidence that there is fecal shedding of COVID. And so though not sort of thought of as a typical sexual fluid, it is often involved in certain sexual practices, especially if there's fecal oral transmission. With that said, like many other respiratory viruses that may have similar shedding patterns, this is not the most efficient mechanism of transmission. So I don't think that we should start thinking of COVID-19 as a sexually transmitted infection, but keep it where it lives as a respiratory virus.
Thank you so much. Someone here is also asking about online porn as an alternative that should be promoted to physical consensual sex encounters with other people during the pandemic. And they are also asking if promoting access to porn is very controversial, even if it can serve as a public health measure. Do you want to take a stab on that, Dr. Daskalakis?
Sure. I mean, I think, and I'm sure others will have a lot of opinions on this one too, because it's very complex in terms of sort of accessing online pornography. I think is a strategy that I think many folks have used during the pandemic for erotic pleasure. I think it's always important to include the caveats that that it's important to remember that that some behavioral changes can occur with repeated exposures to pornography. And so I think in the setting where we also talk about increased domestic violence, it's really important to sort of temper those two. There is no answer from the harm reduction perspective. I think that folks using online resources for pleasure is great. I think that, of course, there's always the give and take of sort of potentially trafficking issues, as well as issues around consent. So I think that it is important to sort of temper that guidance in the public health perspective with some of the other observations long-term made about pornography. So again, it's a complicated issue. I think from the harm reduction perspective, I think that judicious use that doesn't infringe on other people's rights, I think is the best advice we can give. I'm sure others have a multitude of opinions on that one as well.
Does someone want to add something around that? I would be curious also to know, Giselle, I mean, in thinking about your network in Latin America, how are they managing the messaging on sexual health, coming from this perspective on the importance of incorporating pleasure-based messaging and talking about alternatives to meeting in person during the pandemic, such as the alternative raised by the question or the use of dating apps, social media. Can you tell us a little bit on the messaging around this and how it's been incorporated by the organizations who are members of IPPF Western Hemisphere region?
Yes, I think that hasn't changed that much. Our sex ed and our work around sexual pleasure, is evidence-based. It's really empowering, and we respect people's desire and support people's desire to seek pleasure. And I think probably Jhonny can talk a little bit more from the perspective of Bolivia directly. I have not seen any data yet from the rest of our partners as to how, if things are changing in that regard. If we have big youth programs and community programs with young volunteers, and I think this has been central for our sex ed work. Jhonny, do you want to add here anything coming from Bolivia?
Jhonny, ¿te gustaría agregar algo más?
Antón, did you translate, right?
Yes, I will.
Yes, thank you. Yeah.
Gracias. Sin duda, la pandemia ha generado cambios. Sin embargo, nosotros continuamos trabajando a través de la estrategia de llegada a los jóvenes y a la población a la que llegamos, brindando información y empoderando, básicamente. Por eso nos referíamos a que trabajamos en el tema de educación sexual integral a través de tecnología ahora.
The pandemic has certainly generated changes, but CIES remains strong in the same strategy of providing comprehensive sex education to youth and vulnerable populations and leveraging technology to provide sex ed to them. Terry, do you want to add anything in regards to sexual rights and what's happening in the online world, either as an opportunity for service provision to reduce the stigma, some of the things that have been said, or also, what's happening right now in the online world, people going, to dating apps quite more, or this issue of porn being presented as an alternative to having consensual sex in the times of COVID. Do you have any thoughts about sexual rights implications on some of these issues?
I'm not really an expert on that set of issues, but I think that, I kind of agree with everything that's been said. I do think that the space has to be watched very carefully because there's lots and lots of risks, right? Of exploitation, et cetera, and exploitation from many, many different directions. So I think I'll leave it at that.
So I'm just curious to ask everyone for the next couple of minutes if we can maybe think a little bit about the issue of partnerships. And this was something that Ben Wilson raised a moment ago about public-private partnerships. Does anyone have any thoughts on the importance of leveraging partnerships between private, public sectors, and non-for-profit world, academia, post-COVID-19? I think there are different areas of opportunity that have been mentioned, such as the use of technology for SRHR, the data point that you brought up, Terry, and strengthening data systems. And for instance, Ben Wilson spoke from the perspective of Durex as a condom brand, and they collect a lot of data on what's happening on sexual encounters around the world. And so he painted that picture based on their own data. So I'm curious to know if anyone has any thoughts about partnerships for any of these areas of opportunities that have been addressed so far.
Can I come in? I actually, as we were going through the conversation, I was making notes about this because I think as we have a moment to breathe and recover from the big shock of having everything closed down, it's very evident to me the need to create those partnerships to produce quick innovation. I was particularly thinking in the need to do south-north, north-south, sharing. I follow very closely Uruguay as a country and how they have managed COVID, and the fact that in the context of COVID, in a not super progressive government, they determined that safe abortion care was an essential service, that they need to ensure that midwives could actually take care of it. And I heard Demetre about some of the work doing in New York City and thought how much our partners could benefit from these communication strategies that focus on pleasure and safe pleasure. And so I can see how we really need to have more of these conversations, and perhaps a better structure to have some of these dialogues between governmental organizations as well as non-governmental organizations, as we tend to be sometimes more open to try new approaches, and given our scale, we can do that. So I was making notes as we were having this conversation of the so many opportunities that already appear in this space.
Thank you so much for that. Jhonny, Terry, Dr. Daskalakis, do you have any thoughts on this or any closing remarks?
I mean, this is Terry. I agree with Giselle. I think that we need to be talking to each other a lot more across silos. We need to be really, obviously in the context of the vaccine partnership with industry is critical. We can't just leave it to the powers that be. We have to be involved and in conversation. And I think, I think there's huge potential. So I would add that to the pile of opportunities out of this pandemic, that I think it's highlighted that we can't manage things if we don't partner better.
Yes, and I think this goes back also to a project that the AHF Global Public Health Institute at the University of Miami is leading. And so thinking about global public health post-pandemic and the importance of leveraging innovative partnerships. And so a pandemic cannot be solved only by one actor only or by one national government. There needs to be more actors involved in the solution. And so this is the spirit of the new global public health convention that is being proposed by Dr. Jorge Saavedra, Dr. Julio Frank, Michael Weinstein, the leaders of this project. And so I'm curious, Dr. Daskalakis, if you have any thoughts on this or any closing remarks.
No, I agree that I think that in general, the need for sort of more communication and communication that is not just sort of scientific, but also strategic is really key, both sort of, you know, in a local sense and then in a more expansive sense, nationally and then internationally. So I think that all partners are a part of that strategy conversation, whether they be in public health, in academia, in clinical care, or in private industry. So I think that that's an important lesson from actually HIV that we're now moving into COVID. I think Terry, I'm 100% with you that the lessons of HIV are the lessons in COVID, and it's sort of interestingly that we sort of had to learn the lessons or pull out that playbook in an accelerated fashion. So what took a decade in HIV took a month and a half sometimes in COVID. But thank God for that playbook to be able to sort of dip back in. So I think really that's the point, that it's not only about interesting exchanges of science, but also important exchanges that focus on strategy.
Thank you so much. And with that, Jhonny, do you have any closing remarks before we finish? ¿Tienes algo más que agregar antes de que terminemos, Jhonny?
Sí, yo creo que el tema de las alianzas es un tema central. Nosotros estamos muy preocupados en Bolivia, por ejemplo, las alianzas público-privadas con las empresas de comunicación, porque nos damos cuenta que para llegar a los jóvenes necesitamos un sistema de comunicación que ellos dispongan de megas para que puedan recibir la información, para que puedan acceder a sistemas. Y esa es nuestra preocupación en este momento. Estamos trabajando con ellos para bajar costos, para tener un acceso que nos permita llegar a esta población vulnerable. No solamente de los jóvenes con educación sexual integral, porque hemos cambiado nuestras estrategias, sino también a la población rural para que puedan acceder a servicios, porque hay distancias muy largas, la gente de indígena no puede comunicarse, y esos son problemas que en este momento creo que a nivel nacional el gobierno y nosotros tenemos que trabajar.
So definitely this is an important point to consider also in the context of Bolivia, innovative partnerships, and particularly thinking about public-private partnerships to find better ways to communicate with young people, to strengthen communication with young people. So with this, I'm going to finish the symposium. I hope that everyone has some food for thought as we keep thinking on building a better normal post-COVID-19 in the area of sexual and reproductive health and rights. And so thank you so much for everyone at home who joined us. Please stay safe, and we look forward to seeing you in the next panels of the COVID-19 in the Americas conference. Thank you.